Modern primary care clinics are collapsing under a dual structural failure. The physical waiting room has become a biological bottleneck, and the physician's desk has turned into a sprawling administrative sink. Physicians are experiencing what can only be described as managerial strangulation. Highly trained specialists now lose up to 3.2 hours every single day to non-clinical data entry and routine paperwork. Meanwhile, the physical design of the centralized clinic actively amplifies risk. By forcing panicked individuals to travel and sit together, waiting rooms mix infected vectors with vulnerable populations, spreading pathogens before anyone even sees a doctor. This chart projects annual mortality from antimicrobial resistance through 2050. Look at the red line representing standard care. Without community-level interventions to stop infectious mixing and unnecessary antibiotic prescriptions, the death toll from superbugs climbs exponentially. The math is clear. The current centralized model cannot physically scale to meet modern patient volume. Attempting to force more patients through this narrow pipeline will bankrupt practices, burn out remaining doctors, and accelerate transmission of untreatable infections. To fix this, the point of first contact must be moved out of the clinic. The solution is a decentralized biological firewall powered by clinical artificial intelligence. Enter the Premakiosk, which stands for Personal, Resourceful, Empowering Medical Advice. Positioned in local pharmacies and high-traffic community spaces, these standalone terminals act as an autonomous front door to the healthcare system. The intelligence driving this hardware is the Dr. Maya GPT clinical reasoning engine. Rather than a simple decision tree, it uses a combinatorial symptom model trained on decades of clinical experience to replicate the diagnostic pattern analysis of a senior physician. This system builds three distinct architectural layers: the physical kiosk gatekeeper on the street, an autonomous AI administrative assistant managing the paperwork, and an integrated community IoT network linking patients to care. Deploying this ecosystem re-architects practice management from the ground up. It takes the burden off the isolated, reactive clinic and distributes it, creating a proactive, localized health hub. The first architectural layer physically intercepts patients in their own neighborhoods, keeping contagious individuals away from clinical waiting rooms. When a patient interacts with the kiosk, the Dr. Maya engine instantly processes their inputs. It evaluates complex combinations of symptoms to accurately gauge clinical risk. This infographic details a transparent, four-color triage protocol. Green and yellow tiers indicate minor to moderate symptoms, directing cases towards self-care, nursing advice, or a pharmacist. This immediate diversion reduces clinic walk-ins by 25 to 40%. The blue tier intervenes when the AI detects a contagious or antibiotic-resistant infection, issuing a blue code, instructing the patient to isolate at home. Finally, a red code flags life-threatening emergencies, advising the patient to immediately call an ambulance. This localized identify and isolate strategy creates a literal biological firewall. By keeping infected patients out of centralized facilities, it breaks the chain of transmission and starves the hospital of the very superbug reservoirs that make it dangerous. While the kiosk manages the physical flow of patients outside, the second layer of the architecture targets the digital flow of paperwork inside. This chart breaks down a typical 10-hour physician workday. The goal of this second architectural layer is to structurally reclaim the massive 3.2-hour block currently lost to administrative data entry. Integrated directly into the electronic medical record, the Dr. Maya AI operates as an autonomous background assistant. It automatically reads, summarizes, and files incoming hospital letters without requiring any physician effort. It takes the intake data gathered at the community kiosk and uses it to pre-populate EMR consultation notes. If a specialist is required, it automatically drafts the outgoing referral letter. When lab and radiology results arrive, the AI processes them immediately. Instead of piling them up chronologically, it flags and prioritizes them based on strict clinical urgency. For routine matters, the system prepares prescription renewals, sick leave forms, and customized patient education sheets. The physician simply reviews the prepared work and provides a single-click final approval. By automating these exact bureaucratic workflows, the system eliminates up to 60% of routine administrative appointments. The physician's time and focus are returned exclusively to practicing complex medicine. Zooming out to a systems-level view, we see the third architectural layer, The Integrated Micro-Health Network. This connects the central clinic to local chemists, allied healthcare services, and patient homes. By placing kiosks in pharmacies, local chemists are integrated into a formal triage loop. Armed with AI-backed clinical assessments, pharmacists gain credibility and effectively manage minor ailments, creating a highly efficient, seamless referral ecosystem back to the clinic when necessary. This integration translates directly into reduced operational costs. Data shows that deploying a single Premakiosk effectively adds the capacity of half a full-time equivalent nurse. Because the AI handles routine patient queries, medication reminders, and discharge instructions, the central clinic drastically reduces its dependency on mid-level nursing staff, lowering payroll overhead. At the same time, it creates new decentralized revenue streams. Fixed margins from daily kiosk consultations generate consistent income that flows back to the operating clinic or the foundation. The network is maintained by community health navigators. These trained operators extend the clinic's reach even further, facilitating at-home IoT monitoring for isolated and chronic patients. This networked architecture slashes operational overhead while generating sustainable, decentralized revenue, all without depending on the physical presence of the doctor. The sheer scale of this integrated network introduces a powerful macro benefit, a real-time crowdsourced epidemiological surveillance radar. Because symptom combinatorial analysis happens instantly at the street level, the system maps public health in real time. If multiple nodes in a specific neighborhood detect identical infectious patterns, the AI organically flags a sudden geographic cluster. Traditional public health surveillance relies on laboratory results. Because it requires patients to seek care, get tested, and wait for processing, the data chronically lags behind actual community transmission. Real-time street data eliminates that delay. Historical deployments of community-level symptom tracking have successfully identified epidemic onset up to 6 full days earlier than standard laboratory systems. Once a cluster is detected, automated warnings are instantly routed to local doctors and pharmacists. This allows the network to proactively adjust medication stock, update triage algorithms for the new threat, and push targeted health warnings to patients. The network functions as an indispensable biosecurity asset. It grants public health systems the operational head start required to contain aggressive superbugs and respiratory pathogens before they can penetrate and overwhelm dense urban centers. Moving from theory to practice, we can evaluate the hard data generated by pilot deployments of this system. The efficiency gains are immediate. Clinics report a 40% reduction in outpatient department consultation times, successfully redirecting avoidable walk-ins away from overburdened emergency rooms. For patients, immediate access to information and drastically shorter wait times cause satisfaction scores to jump from 72% to 91%. This graphic compares the most critical metric for the physicians themselves. Under standard care, standardized burnout severity scores set at 38, indicating high burnout. With the Prema network absorbing the administrative load, those scores drop to 21, a massive improvement in physician well-being. These metrics mathematically prove that structural decentralization works. It reverses the operational decay of the primary care model, creating a system that actually functions for the people working inside it. A common anxiety in modern medicine is that opaque, black box AI algorithms, dictated by corporate administrators, will eventually render human clinical judgment obsolete. Prema is built on a transparent, open architecture. It is designed explicitly to act as an extender of the physician's expertise, never a replacement for it. Doctors retain the ultimate override switch. The physician maintains absolute authority to adjust triage thresholds, add localized red flags, and overrule any AI recommendation based on their own judgment. The result is an interconnected solution, a biological firewall protecting the physical clinic, an administrative AI freeing the doctor's time, and an epidemiological radar protecting the broader community. The Prema ecosystem is an urgent institutional recalibration. It ends managerial strangulation, bypasses failing infrastructure, and fully restores the professional sovereignty, profitability, and time of the